Okay, good morning, everybody, and welcome to our Hospital Partners webinar. Thank you for joining us. My name is Dr. Katie Lima. I'm the Vice Chair of Pediatrics, and I'm stepping in to help out with the webinar today. Today, we are going to discuss the considerations for reopening some of our healthcare facilities, as well as steps towards reopening or thoughts about reopening the state in general. And it'll be presented by Dr. Ron Johnson, who is our Chair of Obstetrics and Gynecology here at RUHS. Just a little background, just remember, please, if you've not already done so, please mute your computer or your phone. And if you have any questions that come up while we're discussing, please use the chat box and we will get to those as much as we can at the end. If we can't get to everything, we will try to answer via email in this coming week. And then we're also going to discuss a few things about reopening a few different sources that Dr. Johnson has used. And so hopefully if you have any questions or want any of those sources, we'll try to email those as well. Dr. Johnson reminded me that also RUHS has come up with a COVID app where we have been housing all of our policies as they change quite frequently, created by one of the attending surgeons here at RUHS. And so if you have any interest in that, we can try to get you the link or the QR scan in order to join the app. Just as Monday morning, I'll give you the numbers of the county as they are right now. Right now, there's 32,000, almost 33,000 people tested in the county with 2,638 confirmed cases and 75 deaths as of this morning. 223 patients in the county hospitals, as well as 71 of those being in the ICU. So that's where the county stands as it is today. And again, if you have any questions, just go ahead and open the chat box and we'll get to those. And we're gonna have Dr. Johnson talk about thoughts about reopening our healthcare facilities.
Good morning. I appreciate all of you joining. A lot of our effort in our system at the RUHS Hospital Medical Center and system has involved clearing things through Incident Command Center, and we've tried to do that in order to standardize the message that we get out and some of the ideas we're looking at. As everybody knows, all this is a work in progress. I mean, every day when we release guidelines, and I specifically do to my department, I always put at this time, because at the next time when I release that information, it may be different. And part of it is gleaned from what we think we see going forward and a lot of modeling from what has happened. So our physicians have been in contact with physicians in Milan to find out what worked and what didn't for them. We've talked to them a number of times. And then of course we have a significant body of evidence from New York, Louisiana, as it came across the United States. So we've used those for our models, and our models have been worst case scenario. The good news is that we seem to be flattening the curve and not getting to that point that we hope is because of our mitigation efforts. But that's been the good news that we've seen here. And we were actually caught a little bit by surprise because of our numbers that we might be talking already about reopening. And reopening is a work in progress also. So we, just to give you some idea, I'll ask if the IT team can put up the national, American, what is that? The AEI document for people to see, because that's one of them that we, and can you, oh, there we go, perfect. That's that to me, the AEI document is a very easy read, and it's something I think your institution or you can hang. It's a coat rack to hang your coats on, and so you can talk the same language as everyone else is talking and get some fantastic ideas and make this custom for your facility. Then there's also, can you show the other one, the guidelines one? Everyone probably has seen this because it was the one that came from the federal government, opening up America again. And you'll notice the language is a little bit different as far as phases, but the object and idea is still the same. And neither of these are particularly complex. I have very detailed references that we can get you if you wish after this is over. I have a long support document from the American College of Surgeons. I have a collaborative document from the American College of Surgeons, anesthesia and AORN, and also a scoring system if you have a very big hospital system, operating system, as to what cases become priority when we start up again. And it may or may not be something you can use, but all of that is out there. It's starting to be out there. For us today, I wanted to go through a short PowerPoint that gives us some idea of where to start, I think. And then for detail, you can refer to, if you want to write detailed policies for your hospital, or like Dr. Lima said, go to our RUHS COVID app, which some of these will be up there. Then you can use that to fill in some questions and some of the about some of the details. All right, so can we open up the PowerPoint, my tech friends? Okay, that actually is my document that's that I did a redux of the AEI one, so that you can see what I think are the triggers that move you to the next stage, going from stage 1, which is really still the surge mitigation, and then what puts you in stage 2, which is part of the recovery. Can you guys open the PowerPoint? No, yes. We had a lot of documents to share for you that are listening, and that's why they're kind of looking through the ones. Don't see anything yet. Okay, what I'm going to do is, it's a little short presentation, and in the interest of time, I'm going to read my slides. It doesn't matter, I don't think, if they're up there. So the number one thing that is very, very important that we're stressing most among our different groups in the hospital that are working on this is that we have to know our community statistics, and that's why Dr. Lima read those to you. Everyone was interested. Everybody wanted to know where we were. And we need to know what the COVID-19 prevalence incidence, whatever we're measuring is at, to start that when we start the reopening, because it's going to be imperative later when we go back to look to make sure that we're not going backwards and that we're moving the needle still in the correct direction. And the other issue for us is knowing what our COVID-19 diagnostic testing availability is. Most hospitals didn't have testing for this in their labs, so a lot of it has been acquisition of equipment. And Abbott has 2 different systems out there. Cepheid has a module. BioFire is another company. All of these have the ability to test. Unfortunately, because this is new and ongoing, and we don't know what the cross testing is with the other coronaviruses that routinely come through, we're not sure yet of all the true false negatives and positives. But I think my assumption would be right now that we're about a 30% false negative rate, and we're not sure how big the false positive. All of these work a little differently. You have RT-PCR, You have ID, you have serology that can look at IgG and IgM, and that's being talked about way down the line of testing those people, but not immediately. And they could differ from needing 1 part in 100 to be positive, or they need 1 part in 1,000 to be positive, and they're not all the same. So I think you need to know what you are using as your test. Are you sending it out to public health? Public health will give you a 24-hour turnaround. We find that we're still 5, 6, 7 days out when we use the standard labs that we're working with. But that is the first thing. If we don't have data and statistics to compare to, you're probably going to struggle a little bit in your response. The second thing that we felt is important is that we know our capacity. Every morning when we have had a joint meeting, we find out from nursing how many ICU beds are available, how many non-ICU beds are available. And I think knowing back when we had the surge and now we think post-surge, what are they available? How many ventilators do we have? All that detailed information, because when we get to the point where we're back in operation, we already all have busy hospitals, and all those resources may be, well, they will need to be available for all those who come. And so knowing that we have at this point the volume that we could still keep 50% of them open for our regular throughput patients is important to us, so that we say, okay, we could still deal with COVID. It's not in a crisis situation anymore. How can we deal with it and still deal with the numbers? Also, workplace staffing, people have struggled with, to make sure we have enough nursing. We can open 3 ICUs, but if we have nursing for 1, it doesn't help us to have 3 ICUs open. OR supply chain is important. If we start doing surgeries, are the other entities that we get supplies from open or closed? Can we get all that we need? And is there medication availability also for them? The second thing after testing is protection. And we are talking about protection of non-infected patients that come to our hospital, but also our staff, which is very, very important to us. The moves that were really changing rapidly in early COVID was how safe do we need to be, how limited in contact do we need to be, and that was a work in progress that moved forward very, very rapidly. And so if we're ready to move forward, we have to decide, do we have the level of personal protective equipment appropriate for the staff and whatever position they're in, if they're in the ICU or in the OR, and can we do our regular volume? Do we have enough suffice to do our regular volume and still be able to do our PPE for our sick patients? We also have done masking for staff and guests. Even after recovery, I think that's going to be vital, is that we try to stop contacts, because that is where the obvious spread is. We all have visitor limitation. I'm from OB, so ours is a little bit different. We realize the emotional benefit of having a support person with them. Even that, depending on canvassing hospitals across the United States, is varied. Some of them will not let any support people. That's very few. Most of them will allow 1 and kick them out at the postpartum as soon as they become postpartum. And some of them are allowing that person to stay through postpartum and help the mother deal with the baby. And none of these, of course, have any data, whether it stops or doesn't stop the spread. It's just our way of being able to say, we're going to put the policy in place, measure what happened, and find out on the other end. And at the same time, we want, that abundance of caution, like I mentioned. So universally, I think that most are in agreement, because of the 7-day course and the 3 to 5 day incubation period, that if you're going to resume operations in your facility, we want a reduction of rate of new cases for 14 days. So that doesn't mean you have to be at 0, but we know that we aren't doing getting close to, for instance, the doubling time, which was it and still is a very popular way of looking at how rapidly your cases are increasing. And we also want to know the same about PUI. Are we having to investigate less people, the rate of those people coming in for 14 days? And then what is the rate of people coming to our ICU for 14 days so that we know that there's a drop off and we can take care of and house our patients. So to us, that's probably the most important criteria that we can agree on before we open. And then depending on our facility, we can look at testing, we can look at PPE and all those other points that are important. COVID test 19 testing, interestingly enough, had when the units were out and people were looking at purchasing them, they didn't come with enough tests to be used. So we have to make sure that if we're going to say we want to test all our pre-op surgical patients, we want to test all the staff that are in our units, do we have enough testing kits to do that? So I think that's very important. I think that what we also nationally understand is that in order to that testing everybody would be perfect, even with false negatives and false positives. If we tested all of our patients, but we're still not there yet. We also, so for that, I say we have to establish guidelines of who gets tested first, and how is that going to apply to our cases going to surgery? If, say, we work them up 2 weeks before and we're doing surgery 2 weeks later, and they had a negative test, then do they still have a negative test? So those guidelines are the ones that you will find more detailed information in articles from the American College of Surgery, and the collaborative articles with anesthesia and surgery and AORN. So I think that's probably something you're just going to have to look at it as it evolves, because a lot of that is pre-publishing journal articles, so they haven't made it out to the public, but it's what we think. One of the things in obstetrics we realized because of early data from Columbia Hospital in New York was the high degree of asymptomatic obstetric patients coming into the facility, and it was in their group as high as 30%. So that then led us to think we need to test all of our OB patients regardless of symptoms, so we have some idea. Our unit is split in the hospital to be able to isolate positives and PUIs from negatives, but our struggle has been to know at the time when they come in whether they're PUI or if the baby's going to be born before we get information. We wanted to know. Speaking a little bit in generalities, also to our surgery system, restarting our elective surgeries. As you know, elective surgeries don't mean surgeries that don't need to be done. It's just surgery that we don't have to necessarily do right now. And there are a number of actually fairly complex algorithms. One of them is the I'm forgetting the name of it now, but that is one system. If you have a hospital that people are going to have to share ORs with, how are you going to prioritize the cases? And then our thoughts were that we would do our outpatient surgeries first, because that would save beds in the hospital if we should get a resurgence, and then probably going towards 50% capacity for a normal OR, then maybe 75%, and then 100%. But the most important aspect of that, we feel, is the initial 2-week reassessment, because we need to say, if we're going to continue going forward, did we have a resurgence? And in the AE article that we looked at, I liked the spot that they said at the end of each phase, you're going to look at your numbers and decide, do we have to start back at the beginning again in phase 1? And we thought we were in phase 3 or whatever the phases are numbered. So I think it's important for your institution to say, after 2 weeks, can we go from elective to inpatient surgery, and do we want to do 50% for a week, 75%, or you may want to be at 2 weeks for those, and look to make sure that you still have a declining prevalence in the community while you're opening up your hospital and moving forward. I think other than that, if anybody has any questions, we'd be happy to answer them. Or if anybody would like any of those materials, as I said, we're going to eventually put a lot of those on the RUHS COVID site. In fact, we could, if you want us to email you the how to get the COVID app with a QR code that you can just you can match with your phone, we can also do that. So any follow-up that you need, we can become very, very detailed with what we have. Again, these are new articles coming out. Some of this must change, but some very, very intelligent people nationally have taken this on and I think published some good data.
Thanks, Dr. Johnson. I just wanted to remind everybody, as far as the testing is concerned, RUHS just opened their 5th community testing center. So there's now 5 areas in the county where you have to make an appointment still, but you can get testing. And the last Instagram post implied that they would also test asymptomatic individuals, including children. So again, everything sort of hinges on the idea that we actually know the numbers, and we won't know the numbers and the statistics without the testing. And so there seems to be the county, again, pushing forward and making strides to get us the numbers that we need. So they've opened a 5th test site and have reportedly said they will test without symptoms. So if you just want to know your testing status. And I agree that we have to start thinking about how we're going to test the healthcare workers and the people in the hospital and kind of phase through how to get more data that way. And the capacity, that's why the Dr. Leung and the group for the public health side have also added the hospital capacity in the county, how many beds, how many ICU beds are being used, because the percentage of beds you need, how many per every, I think it was 5 to 7 per 10,000 or something was one of the numbers I saw. So basically doing a lot of math and statistics to know that this is how many people you have in your county, how many cases you have, and how many ICU beds you can expect to need because of that, to be able to move forward through the phases. Does anybody have any questions or comments in the chat box regarding these strategies? Again, we'll send out the documents from the AEI. It's really, really easy read and really informative read. Great ideas, I think. And I think that the county and the state are kind of pushing the same way. And when I looked at that and then reread what Governor Newsom had said, it seems that he had been told all this, because his plan seemed to pretty much align with everything that was in that document. It feels like the state is also ready, and basically the West Coast is ready to sort of slowly move towards those same ideas, which is also important that we do this in concert. Any questions? Anything else to add, Dr. Johnson?
No, I think that with all the complexity that's going on, when you can think of reopening, I would say testing, testing, testing. You need to find out what your resources are to test and what your turnaround time is. The second one is the continued PPE, if you're having elected people coming in versus your sick people, and to continue masking your visitors and staff, and so that you don't, so that we don't have another surge. I think it was the Spanish flu epidemic that had 3 surges. You know, every time they went back and opened up the schools and then opened up workplaces, they had another surge. And that's what we don't want to, that's what we really want to avoid.
Yeah, that document you sent out with the AEI is addresses those kinds of things. I think that the public needs to be ready to wear their mask for quite a while, from what I can tell, like months and months. Even if we're getting back to normal, that we probably should be, or whatever normal will be, that we probably should be masking that whole time, and that there was carve outs to how to start the schools up, but do it in a way where they're a little bit more distanced and a little more frequently deep cleaned. And that we should be continuing to like kind of live with the masks for a while. We got a question from Yolanda about masking children. I'm Pete, so I think I'll answer that. A guideline I saw, let's see, was to not mask children under 2 for a safety hazard, because who knows where the mask will end up. And that children above 2 should be watched closely, particularly like in the 2 to 8-year-old range, just in case they're struggling with it or it's getting in a weird spot. And above that, or basically school-age children, you still want to have a mask that fits them, not kind of a big one that goes above their eyes. And just watching them close. My children are getting masked if they do a walk around the neighborhood. They so far have their 5, 8, and 13 so far have been tolerating it okay. But yes, in general, the kids should be masked. They should stay home as much as possible right now and not really go on the trips to the store if that can be avoided. But if they go, it's best that they cover their face if they're over 2. Any other questions? I was expecting a little bit more chatter on this topic. I think that probably it's a lot to digest, and we'll send out again those documents, and the county continues to move forward with their testing procedures, and each institution is trying to get the quickest test possible with the most accuracy. It's not an easy thing to do, but I think that's going to be our very first step of whatever phase we're going to call this in order to get closer to the next phase, which will be lighter distancing, it looks like, but still masked and still no big, I'm a little concerned about football season, if I'm being honest, but no big gatherings and so forth for a little while to come. Well, I think that was all I had on the topic. I had taken some notes too, and like I said, like Dr. Johnson alluded to, the app is a really good source. The Rivco Public Health site, if you're not already on it, as well as their Instagram site, is super informative and can show you where the county is, which is aligning well with where the state is, maybe even a little bit ahead. So I think the county is doing a great job, and these kind of efforts where we talk together and kind of do this in concert will continue to move us to where we want to be. But if there's any other questions, we'll give it another minute. Otherwise, we'll send those documents out through the meeting. And I really appreciate Dr. Johnson for joining us. Thank you so much. And I believe Dr. Versio returns tomorrow to spearhead this again tomorrow. So thank you, everybody.
And thank you, Dr. Lima. So everyone is leaving, and then you don't shut it down till Elvis has actually left the building?
I guess so.
Yeah, okay.
that's pretty much everybody.
Just us now.
We're gonna be the only people looking at each other.
Just us. Everyone's gone. So
I know. Even our tech team, I think, is gone. Oh. I think it's just us. Thanks, Ron. We'll talk
right.
to you
Thanks,
later.
Katie.
So, I'm
Talk to you later.
sorry. So
Bye.
you guys, what you guys could, I'm sorry, we should have explained that.
We were just
But
staring at each other until everyone disappeared.
no, normally you can just hang up, and then everyone who doesn't, I start excusing them from the room. So then it's just left with the webinar host, and then the video will end.
Gotcha. Okay.
All
Well,
right,
bye,
you guys have a
everybody.
good
Thanks for
day.
your help, everybody. Appreciate it.
Thank you. All right,
Thank you.
bye.